everyone, and welcome to today's webinar. My name is Holly Seidel, and I'm the Marketing Manager here at Nextgen office. Today we are presenting Financial Success as an Independent Practice. I'd like to start off by mentioning a few housekeeping items before we get started. We will be asking the audience a few questions during the session. If you could please type your questions into the Q&A section, we'd appreciate it. We will also be answering questions at the end of the webinar. Today's session is being recorded and will be available to everyone who registered for this webinar. We'd love to hear your feedback after the session. There will be a short survey that will display on your screen after the session ends. Please take a few minutes to complete it so we can continue to make improvements for future educational webinars. Now, without further ado, I'd like to introduce our speaker, Christine DeFrancisco. Christine comes to Nextgen office with 20-plus years of practice administrator experience. For the past 2 years, she has been the Acting Director of Revenue Cycle Solutions here at Nextgen office, providing independent practices with her tips and advice on why revenue cycle management is so important.
Thank you so much, Holly. I appreciate it. I've broken this conversation up into 4 different sections. One is I want to talk about the changes in the marketplace today and how you can pivot to increase your financial success with the dynamics of today's marketplace, how you can benefit from implementing those changes, taking a look at partnerships that you can develop when you're making these changes, and then help identify potential solutions that work for your practice. So one of the big things that we see with healthcare that's been going on probably since the beginning of time is it's incredibly dynamic. So we have a healthcare landscape in our country that is chronically evolving, so I'm going to talk about that. I also want to talk about common mistakes, so that way if I'm calling out any mistakes that are sort of intrinsic, that this is not native to your practice, that these are systemic issues that all practices face in one way or another. I also want to give you some of the solutions to improve your revenue cycle and then also streamline your patient payment process. I'll speak to the patient payment process throughout this conversation because I think it is such a key in our landscape today is empowering patients to pay. So couple keys with changing in the healthcare marketplace. I'm sure you've been on plenty of these conversations where we're talking about value-based care. And it's just the simple idea of improving quality as well as outcomes, as opposed to this fee-for-service model, which is get paid for the volume you're doing. And really the idea is that it shifts us to focus on overall wellness and prevention, and to be proactive instead of reactive with our patients. And it also folds in this concept of creating standardized healthcare processes by establishing fundamental care pathways. And the bottom line is really what they're looking to do is have patients move through an integrated system more effectively and quickly, which should result in better overall patient outcomes. Really my personal bias is that we are recycling a lot of the ideas that we've had. We tried value-based care back in the 80s. A lot of states do, capitated, risk contracts that, is really more heavily focused on this value-based care. But realistically, this is not going away, and we need to know how to manage our practice around providing this outcome-based care as opposed to fee-for-service. One of the biggest sort of pushes towards that value-based care is our MIPS and MACRA. So I wanted to start out with, I hope everybody knows that if you are one of our podiatrists, on the platform. We do have a press release that went out, I believe, last month, where we have a partnership between the APMA and Darina Solutions, and part of that is going to help you to report your best measures directly to CMS and compare your quality scores against other podiatrists. So you can always reach out to the customer support or your sales exec if you want more details about our integration with the APMA and Daria. But, you know, when I was doing research to create this slide deck, I was really surprised to find that 91% of eligible providers attested in 2017 to avoid that negative payment in 2019. And what that qualifies to is almost 600,000 clinicians attested in 2017 to avoid that, you know, negative or neutral payment adjustment. So this is going to be the first year, 2019, where you either get that plus or minus 4%, and of course that goes to 5%, 7%, and 9% respectively, all the way up to 2022. So you know, again, we're seeing the evolution of this value-based care, you know, in the MIPS and MACRA, and I can say when CMS gets a response of 600,000 eligible clinicians reporting in that 2017, it's not going away. So you guys need to figure out how to attest, leverage the software to do so. You know, we have a fairly robust platform when it comes to MIPS and MACRA within the software, so really understanding how that dashboard works, how you can choose your matrix is going to be really important. I have been saying this next bullet point for at least the last 25 years. You have to start managing your medical practice like a business. So oftentimes when I'm consulting with physicians, the overarching, you know, sentiment is, I am here to practice medicine. I don't have time, you know, to do what you're asking me to do. But realistically, you have to be able to commit to running your business like, or running your practice like a business. Couple other things when we talk about the change in marketplace. I don't think this is going to be a surprise to anybody, but we are in the era of high deductible health plans. I was surprised, though, to find that 60% of Americans are insured by their employer. You know, I don't think that's necessarily, you know, 60% of all of your patients are going to have a commercial insurance, because you know, the geriatric populations or the underserved with the Medicaids may be seeing the doctor more often. But what it does mean is, again, we have to structure the business of a medicine to accommodate these high deductible health plans. So, and again, I'll be speaking to that point throughout this conversation. Consolidation of the small practice marketplace. So what we've seen is a real slowdown in this over the last probably 3 to 4 years, probably because 10% of physicians were acquired between 2007 and 2013. So, you know, there was this huge uptake in the last, you know, 10 years, with a slowdown in most recent years to do that acquisition. What we're seeing, though, is most physicians that were willing to sell or willing to merge or be acquired probably have done so. You know, for those simple facts of they lack bargaining power, right? So we see a decrease in reimbursement and no ability to effectuate that. Certainly you have economies of scale when you are talking about a merger or an acquisition, where you may have equipment that's not routinely used. You may have open space, employees that aren't leveraged to maximum capacity. When you start, you know, when you have that consolidation of the marketplace, you get those economies of scale. Another thing that I hear a lot from doctors is that increase in the regulatory landscape, that they cannot keep up on that, and that affects their ability to stay independent. But most of the acquisitions have been with these large health systems as opposed to larger groups acquiring smaller groups. One thing that I always speak to when we're talking about consolidation in the marketplace is that cultural shift, right, where you're going from that small, relationship that you've had for a long time with patients to a larger conglomerate. So let's step back for a moment. We're talking about high deductible health plans. What we end up having is we now have a patient that has skin in the game, and they are now a consumer. If they have to pay for their care, which is what a high deductible health plan essentially does, is they are now a consumer. And so there is an importance when you're dealing with a consumer-based environment that you have an online presence. So Nextgen Office has developed 3 relationships between Doctable, Patient Pop, and Red Spot Interactive to help expand your online presence. So, gone are the ages where you're with your physician for 25 years, he knows your history, he knows your family, you have a relationship, and now it really is a consumerism-based environment. So you need to have an online presence when it comes to reputation management. You need to have somebody managing your website, patient engagement, social media presence, things like that. So, and these are direct integrations that fold on top of the Nextgen Office suite. So I definitely recommend, sort of taking a look at, if you don't have a robust online presence, talking to your sales rep about potentially beefing that up. So when we talk about the patient as a consumer, we now have to focus on patient-centered care. So again, 2 key takeaways I'd love everybody to have is patient-centered care and running your business running your practice like a business. So you have to have access to care, whether that's opening up hours that may be inconvenient to you guys, but having early morning, late evenings, maybe not every day, but on certain days of the week where patients can access you. You also have to be available for new patients. You are going to lose your throughput if patients have to wait weeks to get on your schedule. You also have to respect patient preferences. We are in an era where patients are going to be Googling, they're going to be going on WebMD, self-diagnosing, self-treating, and they want some say in their medical care. So being respectful of, that input. It's also incredibly important when you have a patient as a consumer that you're coordinating and integrating their care with their other providers. You're informing and educating them as you're going through. Again, the physical comfort of your office space, of how welcoming your staff are, also creates that emotional support that patients really do need this day and age. Patients also now want family and friends to be involved. They want that exchange of information. They want to make sure, within the space of being HIPAA compliant, that you still are making sure that all key stakeholders that are involved in that patient's care, because oftentimes we've got, sons and daughters driving patients to appointments. So, making sure that you're coordinating with those friends and family. And then making sure that there's continuity when we're transitioning patients between specialists, right? That you have that ability to access, patients have the ability to access it through our patient portal, through, our premium document management. There's ways that we can do this effectively in today's landscape. So that's sort of the change in marketplace. Now let's talk about some common mistakes. And again, I specifically highlight the next couple of slides because these are systemic issues that really each practice has probably seen at some point in their evolution. Again, making the revenue cycle, making your billing process a priority. So when physicians are polled about sort of what is one of the biggest impacts in your happiness and your solvency, it is number one, reimbursement. That's physicians' number one chief complaint and concern about their business. But again, then they don't make the business a priority. So, you know, there has to be a balance. And while I know doctors don't go to medical school to learn how to run a business, they have to understand that that's the landscape that we're in. I think part of that is benchmarking your financial performance. I benchmark against the MGMA, which is the Medical Group Management Association. So that's an association of peer thought leaders on how to manage a medical practice. So when I throw out these statistics, you know that this is not Christine saying this is how it should be. This is really industry standards. So net collection rate. So the way we define that is what you should be paid if you had the fee schedule of every one of your payers. So this is what you should get in the bank based on your payment. So the way we calculate that is we take your charges, subtract out contractual adjustments, and then divide that, so that's what you should be paid, right? Charges minus contractual adjustments, and then you divide that by what you actually got paid. So you divide out what you should be paid by what you actually did get paid. MGMA benchmarks that at 95%, which means you should not have more than 5% of your revenue leakage, or 5% of your revenue leaked. So that means patient underpayments, bad debt, denials, insurance underpayments. So you need that at 95%. Another key benchmark is you should not have more than 10% of your insurance AR over 120 days. So, you know, once you get into that 120-day mark, you're going to be running into timely filing issues. Your overall AR, average days in AR, should be ranging between 20 and 30 days. Certainly if you have a high Medicare population, if you deal with significant amounts of geriatric patients, then it should be lower, right? Because we know Medicare pays at a much quicker cadence. Your denial rate should be less than 2%, ideally about 1%. So these are the particular benchmarks I use. You certainly don't have to use these if these aren't meaningful for you, but you know what I would challenge any practice administrator is you still need to be benchmarking. And don't benchmark on what you're currently doing, benchmark on what you should be doing. And start slowly getting to that point. Like if your average days in AR right now is 60, try to get it to 55. And then once it gets to 55, try to get it to 50, right? So start making those small pivots to see improvement. So when we're living in this high deductible market, we need to make sure that patients understand their financial responsibility. I think that this ends up being a huge gap in practices today, that we don't always empower all or educate all of our staff to understand how they effectuate the revenue cycle. So a lot of us think that the revenue cycle is our biller, our back office person, but really anybody who is touching that patient affects the revenue cycle, and primarily that biggest hole happens to be at the front end, at your front desk or your financial clearance moment. So when you get a patient on the schedule, you should be collecting their eligibility as well as their benefits, and then having that conversation to say, by the way, Christine, we can see that, you know, you're going to have a $40 copay, but in addition, you haven't hit your deductible yet. And it is our office policy to have you pay a portion of that at the time of service or make a deposit towards your deductible, something like that. But educating the patient to make sure they understand that the financial responsibility is really theirs because it's the contract that they have out with their insurance carrier, right? So you need to create scripting to help improve that ask. So I get this question a lot, is how do I improve the ask, right? That I spoke a little bit that all scheduled patients must be financially cleared. So in addition to getting a patient registered or creating that medical record, you also need to then be checking benefits, confirming that they don't need or you already have the pre-auth or pre-certification for that visit, but then also letting the patients know what their benefit structure is. That if the patient understands what they're going to owe prior to coming in, it's going to significantly improve your ask. So you also have to make sure that your front desk is comfortable asking for money at the time of service. And a lot of times this is accomplished with custom scripting, right? Create some scripts that your front desk can put together. For instance, you don't say, would you like to make a payment today towards your outstanding balance? You can say something like, we see you have an outstanding balance. Would you, or how would you like to pay for that today? Instead of asking, would you, you say, how would you like to pay for that? And making sure that you have that patient education and compassion. I always like to use the example of dentists. Dentists has got this down to an art, right? You go into your dentist, and if you are not willing to pay to have your cavity filled, they will schedule a follow-up appointment and do it at another time. And they have culturally set that up with their patients to expect that, right? So we need to start creating a culture of expectation. And I'm not saying that you have to necessarily be turning patients away, but you also can't be afraid of what a patient's going to say if they're obligated to pay. Part of that obligation is being more successful is creating a policy, right? Scripting, so everybody's asking in a uniform way and knows how to ask appropriately and training on that scripting, but then create a policy. So that way your front desk don't feel like, well, they're just hanging in the wind, that they know what the policy is, they know when to escalate if there's issues, they know when to back off, and they have a standard experience, right? And then you'll have that cultural shift where patients are going to start that expectation to say, oh, I know I'm seeing my doctor today, I need to make sure to bring my wallet, right? You also have to monitor results. You have to do this by employee, you have to do it by patient populations to see if there's specific gaps, right? Oftentimes it's an employee gap. You have one employee that's really bad at this, uncomfortable, that's where additional training and potentially, you know, I've had practices where one employee does all the check-in because they're comfortable with it, and another employee does the checkout and the reschedules and does more of the clerical work, so they are not having to do that ask. So I would love to know what people's feedback are. If you want and you have specific benchmarks you track that are meaningful to you, I'd be more than happy to sort of get your feedback. You let me know, and you can put it in that Q&A box. It should be probably on the bottom right of your screen. But I'd be more than happy to sort of share your experiences with the rest of the group. And we'll be checking that throughout this webinar. All right, so a couple more common mistakes that we see with practices is not allocating enough time for AR follow-up. So what I see often with your billers is they have enough time to get your claims out the door and post the payments that are coming in, but they don't have enough time to work everything else. You should be getting your claims. This is a good benchmark, again, from the MGMA, that you should be getting claims out within 24 to 48 hours, but no more than 72 hours after the encounter. I know a lot of times you are at the mercy of the rendering provider completing that encounter, but you cannot be waiting to get your claims out the door. I know that it's a big trend today that at the beginning of the year we hold claims because they're going to pay their deductible somewhere else. You are playing a very dangerous game with your cash flow, and the better idea is improve that ask for it up front. So when we're talking about making enough time to work your AR follow-up, MGMA states that only 85% of claims are paid on first pass. That means 15% of your claims by volume are likely not to be paid at first pass, and that's where you have an opportunity for improvement. I can say, so I specifically said 15% by volume because it's generally your high-value claims that are going to be denied. It's your procedures, your J-codes, your surgeries, you know, the expensive services that are more likely to be denied. They're less likely to be denying things like a 99213. They're going to be denying those expensive procedures. So you're not looking at a 15% opportunity by dollar. It's probably much greater. And so part of those unpaid claims are going to be ensuring denials and underpayments are addressed. So when you're talking about 15% of claims don't get paid on first pass, MGMA did a poll recently that only 35% of their providers are actually appealing their denied claims. Because oftentimes it's not difficult to get the claim out the door, it's not difficult to post the payment, but knowing how to appeal it, what needs to be appealed, what format, things like that, and then again, making sure your biller has the bandwidth to do it. That you need to make sure that you're following up on the outstanding AR, you're looking at what is unpaid, and then you're appealing those denials and underpayments. Additionally, I always suggest creating a standard write-off policy. You do not want your billers to be appealing, you know, a $20 lab and leaving a $2,000 surgery out there to be appealed. And I know that sounds obvious, but I can't tell you how often that happens, specifically because it's a lot easier to appeal that $20 often. They know how to do it, they see it a lot, as opposed to the more complex appeals. So create a small balance write-off policy with patient balances as well as your insurance AR. So when we're talking about the working your AR, I thought this was really poignant and I want to make a point. When you financially clear your patient, you're more likely to get a clean claim out the door, but you still need to rework that 15% or so of claims that don't get paid on first pass. But if you're not doing a good job coding, doing your financial clearance, getting patient eligibility correct, the average cost to rework a denied claim is $25. So let's say you have 100 denied claims in a month. You times that by the 12 months in a year, that ends up being $30,000 a year in rework. So, you know, the important thing I always like to highlight to practices is risk mitigation. Get it clean out the door is going to save you what could potentially be thousands and thousands of dollars. But additionally, you're then not having to spend that money to rework it. So we know the changes that are inevitable and are going to keep occurring. We also know those common mistakes, which I'm sure we've all felt at some point or another. And so how do we course correct? Hopefully the things I'm going to show you today are going to be really easy pivots. They're not going to be massive monumental changes. Number one is you have to verify your patient insurance eligibility 3 to 5 days prior to the visit. You can do that through our real-time eligibility tool within the system, but it's not just a matter of getting that green, yellow, red stop sign within the system. You also need to then make sure somebody's checking those benefits to see what a patient's going to owe you. I can't tell you how often, though, practices are not checking eligibility prior to the patient visit, or even at all. Again, obligating your patients, ideally for high-value assets, you're doing that prior to the appointment, but then also at the time of service. So this is what is known in the industry as the 50% rule. So there's been several studies. The one I cited here was specifically from medical economics, but I know that HFMA, MGMA, they've all done studies on this, that if you do not collect at the time of service, you are likely leaving approximately 50% of every dollar on the table. So if you could have earned $100,000 from all of your patients in 1 year, but don't collect it out front and wait to drop a statement to a patient and have them pay on that statement, you would only collect $50,000. So oftentimes when you quantify the amount of money you could potentially be losing, it's huge, right? And that's where that improve the ask that we spoke about earlier is really important. So that 50% rule. You need to educate your entire practice on the revenue cycle process. We spoke to that earlier. It needs to be your medical assistants, your nurses. Certainly the biggest culprit is often the physicians, right? They don't make the time to complete their encounters, do their coding and charge entry. If that needs to be baked into their time every day so they get it done. And then, of course, making sure your front desk understands how they impact the revenue cycle with that financial clearance moment. So some effective ways to collect that 50% I want to discuss now. So another one, again, when I was putting this slide together, I just thought, I wonder if there's been any studies on the willingness of patients to pay. So MGMA did a study where over 50% of patients stated that if they knew what they had to pay today, they would be more than willing to pay between $200 and $500 either by credit or debit card at the time of visit. So if you have a patient with a large outstanding balance, if you are doing a high-value procedure that you know a patient's going to have a deductible or an out-of-pocket, then you need to be asking those patients. 50% of the time, they are going to be paying for it. Again, in this consumer-based environment, we're going to have, we're going to start pivoting to this dental, methodology, right, where you're expected to pay for the services rendered. So I think you need to create different pathways for patients to pay and also different payment options. So, of course, ideally, to get that 50%, you want to pay at the time of service. But you also want to make sure that patients can pay by phone. And if you are leveraging the Premium Patient Portal, on Nextgen, patients can pay online through the portal. You need to make sure your staff understand that and can continuously counsel the patients that they can do it. We're going to get a more tech-savvy clientele as we go on, and more patients are going to be willing to just pay online. If you are using our integrated merchant services, which right now is the merchant TSIS, you can actually maintain a credit card on file, so you can auto-decrement out every month. So let's say a patient has a payment plan. According to the payment plan, 15th of every month, you can run that credit card and keep that credit card on file in a secured manner. So how do you create payment options? I know, again, this may be obvious, but you have to be sending out your statements monthly. Or you need to be, I should reframe that. You need to be sending patients their monthly statements. You should be doing this, depending on the volume of your office, no less than once a week. There's a way in the statement module within Nextgen Office for you to say, skip if sent in the last 30 days. If you check that box, you could theoretically run statements every day and not repeat patients that have already had one in the last 30 days. You can also set these, the statements module to queue everything up in an automated fashion so you're not sending them out one by one. So set up those weekly auto runs. Again, making sure that your patients are using the portal. We can also, here at Nextgen, send your statements out on your behalf. We have a vendor partner and there is a pass-through cost, but essentially you just have to transmit those statements to us, and we will print, run, mail, stuff those envelopes for you. So you can always talk to our customer support about getting enrolled in our patient statement vendor, so we can do that on your behalf. I would love to know if there are any other creative ways. So when I managed an oncology group practice, I had patients hit their deductibles very quickly and for a lot of money. So I would set up letters of agreement, which is essentially like a patient contract, and then keep their credit cards on file. I didn't speak to that here today, but are there any other tips or tricks that you're using to get patients to pay? Go ahead and use that Q&A bar on the bottom right-hand side, and I'll be happy to share that with the group. So leveraging that better ask, financially clearing your patients, and then setting up different ways and methods for them to pay will really increase your revenue. Some of the things that I really hope you would see is you reduce your time to collect. Doesn't necessarily mean you get more money, but you certainly get it faster. But by risk mitigating, financially clearing your patients, you should reduce rejected claims, denied claims, not having that revenue leakage, not paying that $25 to rework claims. You need to be tracking this performance in real time. You can use the dashboards on the reports module, but also benchmarking your data. All of these things are likely to also help improve your quality scores, which ties back to the first part of this conversation where we talked about value-based medicine, MIPS and MACRA. Ideally, we would do this in a structured way that can decrease those tedious burdens and those administrative tasks, and ideally, this would result in decreased overhead. So there are different ways you can take a look at if you don't have the infrastructure to do this all in-house, there are ways that you can co-source and partner. Certainly the preponderance of offices are still having their revenue cycle managed by either a biller or an office manager. Sometimes it's a family member, friends. It's been the biller that's been there for 20 years, and that works. You can still have, different pivots, but certainly don't break it, don't fix something that's not broken. There's also co-sourcing, right, where you give out a part of your revenue cycle to a partner where you can just do the follow-up or just drop claims and post payments, and you're doing part of it, they're doing part of it. What that accomplishes is that volume, right? When you don't have enough time to work all of the rejections, denials, underpayments, by taking some of that volume work, then it allows your billing expert to just work on the fallout. We have a plethora of billing partners and billing services that leverage the Nextgen Office platform. I know a lot of our clients leverage this model where you pick a vendor, you outsource it to them, they charge a % of net collections, and there's plenty of really good billing partners out there that can help partner with you, where you focus on what needs to be done in the office, because there's, like I said, a certain amount of revenue cycle that has to be done in the office, and then they just do what can be done remotely. Here at Nextgen, we also offer the end-to-end practice management solution, which is where we provide software and billing as a one-stop solution. If you want information about that, you can reach out to your sales exec, but it's essentially where we do the billing on your behalf and support the software at the same time. So I do want to speak to those last two solutions, right? Using a billing partner or an end-to-end solution where you're outsourcing your billing. because I do think there are some added advantages, and there, of course, are some inherent disadvantages, right? You don't have somebody there that you can walk up to and ask a question, but let's say you don't have the technical capability or the staffing or the bandwidth to do this yourself. Some of the things that I like about outsourcing your billing is you have a dedicated billing professional. These people should be trained, educated on billing. Ideally, they should be experts in your specialty. You do not want to have a biller that's been doing billing in internal medicine for 15 years all of a sudden have to understand how to bill your surgical claims or your labor and delivery claims or your in-office claims, right? That there are so many nuances when it comes to billing that you want somebody that's an expert in your specialty. One of the things that I really like is that they charge a % of net collections, which means that they only get paid if you get paid. So there's this huge incentive for a billing partner to work down every claim and to make time for that follow-up, right? Because if they can get the claim out the door, but if they can't post that payment, they can't charge for their services. So they only get paid on the monies you get paid. So there's a huge incentive for them to do all of that ARR follow-up and not lose that 15%. So let's talk about scalability. What do I mean by that? Let's say if all of a sudden you're taking on mid-levels, or you all of a sudden get a lot busier, or you now have another partner coming in, or you take on more procedures where all of a sudden you're doing more complex work. Is your biller able to have the bandwidth to do that? Oftentimes the answer is no. And what we see often is your back office staff wear many hats. They might be also, doing your OSHA books, your credentialing, doing other things. And as you scale up, you are watering down their ability to collect on your behalf. And it goes back to that point where the #1 physician complaint is reimbursement. Of course it's going to be reimbursement when you don't have the scalability or the bandwidth to manage it. So, a billing professional should have the staffing already on site that as you scale up, they can scale with you. They also have redundancy in the system, right, where if you have one biller and she comes in, 3 days a week for 30 hours, and what happens if she goes on maternity leave, or, he gets another job, or, has to go on medical leave, all of a sudden your billing comes to a grinding halt. That is your business. That is your lifeline to payroll, to, expenses, to your employees' livelihoods. So making sure that you have redundancy in your plans, that if this person goes out tomorrow, what are you going to do? That's where a third-party biller will have another team member be able to step in seamlessly. And oftentimes you can reduce staff overhead. So I talked about that idea when we talked about consolidation of the marketplace, this economies of scale, right, where, I can leverage, 5 or 10 billers to work on 3 accounts. I have those economies of scale. I can then scale up where I have one group just working claim release, another group just working payment posting, another group working just AR follow-up. It creates that economy of scale, which oftentimes when you're a one doctor or a small practice, you don't gain those economies of scale. So those are some of the benefits of outsourcing your billing, either with a third party or as an end-to-end practice solution with Nextgen. So I'd just like to wrap up, and we'll get to the questions in just a moment that you guys have put on the Q&A board, that I want to make sure everybody understands, and generally this is a slide I always present to physicians when I'm consulting, that revenue cycle is truly a cycle, starting with financial clearance, going to coding, charge entry, claim submission, payment posting, AR follow-up and denial management, and then reporting and benchmarking, that everything feeds on the next point in that cycle. So again, if you don't do one part of that cycle well, you're going to end up breaking the whole wheel. And I think that's it. Holly, did we have anybody post on the QA board?
Yes, Christine, thank you so much for the overview. We do have a lot of active questions. Thank you very much for being so engaged, everyone on the call. So the first from Vicki. Vicki is stating that 40% of their patients pay nothing, and then she sends a financial review with a $5 rebilling fee at 60 days. She wants to know if there's any way for the Nextgen Office software to do that for her.
That's a good question, Vicki. I really like the idea of the $5 rebill fee. I think charging, when we talk about are there other things that you're doing to collect on, I think charging canceled appointments, charging for medical records, these are all impacts on your office, and you should. So charging a rebill fee is important. I don't think there's a way in the system to do that automated, but I will be completely honest with this group. I am not an expert on the system. I am a director of revenue cycle, so I oversee what 300 people do here, but I don't physically go into the system. So I would reach out to customer support for that, but I would definitely encourage this group here to be charging for things like that. And again, Vicki, I think making sure that you're educating your staff on how to do that, improve the ask, how to get patients the idea that we are obligating you to pay at the time of service. I also think people should not be afraid to dismiss patients who are really delinquent, that this is your business. So, making sure that you're not seeing patients all the time that aren't paying.
Perfect. So I wanted to give special thanks to Curtis. He had a lot of questions and a lot of great insight, so thank you, Curtis. Going back to the benchmarks and what he is leveraging in his practice, he mentioned diabetes, BMI, smoking, blood pressure. So those are some great points.
I totally agree, Curtis, that you definitely want to be benchmarking any specialty parts of the business. So I'll use podiatry because I'm very familiar with that oftentimes in podiatry you need to be benchmarking your DME, right? Because you are expending that money out the door to buy that equipment or that, braces, strappings, orthotics. So you need to be tracking those specific things in your practice. Smoking cessation is a great one. You can bill for it. If you are tracking and making sure you can actually do that within the E&M, it's in production, it's an E&M charge performance report. If you are tracking those specific things, it should show up there. But that's a great point, tracking those specialties. I love it.
So Curtis had one more great piece of insight. What methods is he using to get his patients to pay? And he's mentioned that he's training his medical assistants to use open-ended questions at the time of service, and that he's a first-year Nextgen Office client, and he will be implementing the patient portal this year. So
yeah, I agree. The open-ended questions and I like the idea that you're leveraging your MAs, right? Because oftentimes we focus so much on the front desk or your billers, but really we need to engage everybody in the office because everybody effectuates the revenue cycle. So everybody should know that if you're engaging these clients or these patients, in the conversation and it's done at all points of service, you're going to start having them build that trust that they want to pay.
Okay, and then I think for the last question from Marizelli, she was wondering if we had any examples of patient payment agreements.
I've been asked this before, and I've been recommended by my legal department not to necessarily provide these. So what I would do is I would literally Google patient letter of agreement, or LOA, and it will give you samples. So what I used to do is I would have a standard, first you need to create that payment policy, right, to say you have example, 6 months to pay an outstanding balance. I would give it 6 months in the practice I was running as an oncologist because we had huge deductibles, but you may want it to be 4 months. So if somebody owes you $400 and your policy is you have 4 months to pay this off, then you can set up a letter of agreement to say, you have 4 months, we would like to do 2 installments of $200, right? And then it becomes a negotiation to say, well, I can't do 200. Okay, then you can do 100, right? And get that payment on file, keep that, and then in the letter of agreement, make sure you pick the date and have the card and have them sign it. And I would sign it as the practice administrator. I would have the patient sign it, and then I would scan it into the chart as a document. So they knew this was a legal document of record. And I would have a standard format I would use every time, but make sure you create that policy to say you have to have, it's the office policy that all outstanding balances are paid within X amount of time. Then there's no ambiguity when you are setting up those LOAs to say, unfortunately our policy here at so-and-so medical practice is you have to have this paid off in 6 months, so let's set up a payment plan to get that done.
Thank you, Christine. So that is a wrap for today's webinar with Christine DeFrancisco. As you see on your screen, if you have any questions, you can email her directly. There will, again, be a survey that pops up right after the session ends. If you could take a minute just to respond to that, we'd greatly appreciate it. And with that, we're wishing you a great rest of your day. Thanks for joining.